Welcome to today's lecture entitled The Gross Anatomy of Vision. My name is Carlos Andres Suarez-Quian. I am the author of this work and will narrate it for you. Let's start by listing the senses: touch, taste, smell, hearing, and vision. A deficit in any of the senses generates significant issues to a patient. I contend, however, that if you were to ask anyone which sense they would least likely wish to lose, it would be sight. Yes, since July 26, 1990, when the American with Disabilities Act was signed into law, it is possible to argue that life has become marginally better for the disabled. Now do the following. Tape your eyes shut and try to go about your daily business. Businesses may not be able to discriminate against you, but is that any consolation? Life remains quite difficult for the blind. Simply put, we live in a world where sight is required, and losing this sense becomes an issue. No wonder so much research goes into helping to maintain sight for individuals. The objectives of the lecture are listed here. We will cover the following: the location of the orbit within the skull, what makes up the bony walls of the orbit, and understand why one is more likely to fracture than the other, the surface anatomy of the eye, the extrinsic muscles of the eyes and how they move the eye and position it to see what we want to see, the nerves that move the muscles of the eye, but also the nerves that allow us to accommodate our eyes to see near and far, and finally, the blood supply to the eye. Let's move to the bony orbit to discuss their location and content. The bony orbit sockets contain the eyeballs, that is clear, but there are also 7 muscles, nerves, vessels, and quite a bit of fat as seen in the slide. You will be amazed at the amount of fat in our orbits. It is the type of fat that is not lost until final stages of starvation diets. When this fat finally starts to disappear, the eyes begin to appear sunken in, precisely because fat has been lost. Here's an image of a volunteer who participated in a 1944 University of Minnesota starvation experiment for 13 months. Note how sunken the eyes appear. As you probably are aware, there are worse images of sunken eyes in the web of individuals who have been subjected to even more devastating diet restrictions. Continuing with the orbits, each orbit is pyramidal in shape. The base of the orbit is an orbital margin. The apex is at the optic canal. Note how the medial walls are parallel to one another and approximately 25 millimeters apart, half an inch. The lateral walls are at right angles to each other. Now, look at the eyeball and realize that it only occupies about half of the length of the orbit. As we saw in the first slide, and again we will see in the laboratory, the posterior half of the orbit is filled with muscles and loose fatty tissue. Finally, the eyeball is not as wide as it is deep. Note the width is approximately only 40 millimeters. Now, why go into all these details about the orbit? Because the properties of the orbit dictate how ophthalmologists must enter the orbit to minimize the risk of damaging the contents of the orbit. Based simply on the geometry of the orbits, note how the medial wall extends farther anteriorly than the lateral wall. Hence, the lateral wall is more exposed than the medial wall of the eyeball and the preferred site in which to enter the orbit when surgical procedures are required in this area. Let's now focus on the orbital cavity as it relates to other regions of the skull. In the drawing, the orbital cavity is indicated in a skull that has been sectioned in the coronal plane. The crista galli of the ethmoid bone and the nasal septum are labeled for orientation. What is clear from the drawing is that the orbital cavity is surrounded by other cavities, and each can impact on the respective adjacent cavity as follows. If a sharp object is pushed through the roof of the orbit, it will enter the anterior cranial fossa. If an object is pushed through the floor of the orbit, it will enter the large maxillary sinus. And if an object is pushed through the paper-thin medial wall, it will enter the ethmoidal sinuses. Now you might be thinking, gee, where does Dr. Suarez live that he's always talking about sharp objects piercing bone or trauma, etc.? Let me assure you that I am quite safe where I live. The point of discussing these issues is that accidents can and do happen, so we must be aware of possible downstream effects of injuries. Here are two examples from the recent literature with nail gun mishaps. The individual on the left described it as feeling a slight headache, and the individual in the middle even stopped to have his picture taken by a friend with the nail through his eye before being driven to the hospital. Finally, there's the extraordinary case of Phineas Gage, who had a blasting cap go off and the ramming stick was pushed through his temporal region, orbit, and frontal cerebral hemisphere. He lost his sight on his eye and underwent personality changes, but lived an additional 12 years to the age of 47, not an uncommon lifespan in the early 19th century. Again, expect accidents because they happen. The final relationship of the orbit I want to point out is the posterior one. If you push an object in the anterior-posterior direction, it will enter the middle cranial fossa, and this one is unlikely to be survived by the patient. Indeed, if you've ever spent any time reading crime novels, you may know that a favorite tool of assassins is this stiletto knife, a long pointed knife similar to an ice pick. I always wondered why this was so, until I took anatomy and realized that someone must have taught assassins their anatomy too. The internal carotid artery runs right smack in the middle cranial fossa, and is at risk of damage in these types of injuries. Now you might think this is Dr. Suarez being melodramatic, telling accounts of assassins, but I did meet a retired CIA agent once who had spent a lot of time overseas and did confirm to me, at least years ago, that agents do receive training with a stiletto dagger, and the eye was definitely a choice point for attack. Okay, back to anatomy, and now we discuss the bony walls of the orbit. Remember, we already know that it is shaped like a pyramid, and now you know it is made up of 6 bones. Let's identify them, which conveniently they're color-coded in the image. The frontal, the sphenoid, the zygomatic, the maxillary, the lacrimal, and the ethmoid. The bones are not of equal strength. The lateral wall is stout, whereas the medial wall, made up of the ethmoid, is paper thin. Indeed, it is called the lamina papyracea to denote this, and is the reason that most real skulls have their medial walls missing. Instead of grabbing the skull from the outside, we tend to stick our fingers into the orbits and pinch the medial wall with our thumb and finger and quickly destroy the paper-thin medial wall. If you have a skull and have wondered if it's real, if it is missing the medial orbital wall, it is real. The relative weakness of the medial wall is also the anatomical reason for how the lesion known as a blowout fracture presents in a patient. Look at the bulging right eye, known as an exophthalmos. In the MRI, the arrow is pointing to the damaged medial wall. Blowout fractures occur from increased pressure in the orbit and can result in an enophthalmos or posterior displacement of the eyeball or exothalamus as shown in this image. Here's another example of exothalamus. This time you're looking at the blowout fracture from above. The white material indicated by the arrow in the MRI is the inflammation resulting from the injury. And here are two CT images of blowout fractures. Note the clear demonstration of the medial wall damage in both, in the coronal plane, left image, and in the axial plane, right image. However, don't go thinking that exothalamus is only exhibited in blowout fractures. Apparently, exothalamus is also manifested in the autoimmune disease called Graves' disease. Marty Feldman was a well-known comedian of the 1950s and 60s and was one of the stars in the classic comedy Young Frankenstein. We now move to the surface anatomy of the eye. And here it is. Now I'm sure, given its importance in literature, you have a favorite saying about the eyes. Here's some of mine. The eyes have it. Unfortunately, that has nothing to do with the eyes. Or dot your I's and, again, nothing to do with the eyes. But here's one by Charlotte Bronte. The soul, fortunately, has an interpreter, often an unconscious but still a faithful interpreter in the eye. They say novelists are great observers, and I've always found that quote telling. With respect to the surface anatomy of the eye, we need to spend a little bit of time presenting definitions, and here they are. The opening between the upper and lower eyelids is known as the palpebral fissure. Where the upper and lower eyelids meet medially and laterally to form joints are known as the lateral and medial palpebral commissures. And the commissures, by coming together, form angles. These angles are known as acanthi, plural of canthus, ancient Greek for corner of the eye. Let's now look at the surface anatomy of the eye itself. I'm sure you know these, but let's review them here anyways. The cornea is the transparent anterior 1/6 of the outer coat of the eyeball. The iris is the varied colored diaphragm seen through the cornea. The pupil is the aperture at the center of the iris, and the sclera is the whitish opaque posterior 5/6 of the outer coat of the eyeball. Looking now at a sagittal view of the eye, let's label the structures we just named to see how they appear from this angle. And here we see the sclera, cornea, pupil, and iris. But in addition, we now see the lens. You'll get more information in a separate lecture in how these structures contribute to sight. If we now focus on the outside of the eyeball, we observe the palpebral conjunctiva, mucosa that covers the posterior surface of the eyelid. The conjunctiva turns back on itself at a region called the conjunctival fornix and becomes continuous with the bulbar conjunctiva covering the anterior part of the sclera. Fornix simply means archway in Latin. Finally, the potential space between the eyeball and the eyelids is given the name of the conjunctival sac. The surface anatomy of the eyelid is the last structure to consider, and given how thin these are, it is surprising how much there is inside the eyelids. First thing you must understand about the eyelid, however, is that the artists of this drawing had to disproportionately draw it so that they could fit all the structures found within the eyelid. Having stated as such, let's add some labels. The tarsus are semilunar plates made up of dense connective tissue and are located between the palpebral conjunctiva and the superficial fascia. The borders are the free margins of the eyelid, and the tarsus attached to the medial and lateral walls of the orbit via the medial and lateral palpebral ligaments. The tarsal glands are modified sebaceous glands within a tarsus. Ducts open on free margins of the eyelid, and their oily secretions form a surface film to reduce evaporation of tears. The tarsal muscles are smooth muscles within the tendon of the levator palpebrae superioris. The tarsal muscles attach the tarsus to the upper eyelid. They receive sympathetic innervation from internal carotid plexus and contract reflexly to elevate the upper eyelid. The orbital septum is a fibrous membrane extending from the orbital margin to the tarsus. It is continuous to the pericranium. On a clinical note, think of the orbital septum acting as a firewall by preventing the spread of infection from the superficial fascia of the eyelids to the interior aspect of the orbit. Remember also that within the eyelids we have muscles of facial expression, the orbicularis oculi. Hence, note the distinct innervation between the levator palpebrae muscle, cranial nerve 3, from the orbicularis oculi by cranial nerve 7. Of course, we also have eyelashes, called cilia, and these are associated with ciliary glands that can become infected and blocked. In reality, both the ciliary gland and the tarsal glands can be blocked, and they present in similar fashion, but realize that the blockage is of totally different origin. A blocked tarsal gland is known as a chalazion. Some books will describe it as a blocked meibomian gland, which will cause dry eyes because tear evaporation now occurs more rapidly, and the condition can be exacerbated by eye makeup. In contrast, a blocked ciliary gland is known as a hordeolum or stye and represents an infection which should be treated with antibiotics. Eye injuries, too, are expressed as a function of surface anatomy. Periorbital ecchymosis, black eye, for example, is nothing more than trauma to the head or face which causes bleeding beneath the skin. When the small blood vessels beneath the skin break, blood leaks into the surrounding tissue, causing the discoloration. Being hit on the top of the head can also lead to a black eye. The thick and tight aponeurosis of the scalp prevents the migration of the small bleeds except down the path of least resistance, which is often the orbit. In such cases, a black eye may develop over a period of days, even though the face did not sustain the injury. A subconjunctival hemorrhage is also the result of a trauma, and although it looks horrible when you see it, it is often the result of a relatively benign condition. Something as trivial as an increase in blood pressure that can result from heavy lifting, coughing, sneezing, laughing, and constipation may lead to the condition. The last structure we need to consider when discussing surface anatomy is a lacrimal apparatus. As can be observed in the slide, the lacrimal gland is located on the lateral margin of the orbit, and our tears travel from lateral to medial when we blink. The tears are collected by the lacrimal apparatus and ultimately drained to the inferior meatus of the nasal cavity, precisely why we need to blow our noses when we cry. The next topic for discussion becomes the muscles of the eye and their innervation. Let's start naming them. The first muscle we see when we remove the orbital plate of the frontal bone and enter the orbit from above is the levator palpebrae superioris. The muscle will not act on the eyeball because it does not attach to the eyeball. Instead, it raises the eyelid, but is specifically not a muscle of facial expression. Hence, it is not innervated by the facial nerve, but instead it is innervated by the oculomotor nerve, cranial nerve 3. We next move to the 6 muscles that move the eyeball. Here they are. There are 4 straight muscles, hence their suffixes end with rectus, and the prefix of their name relates to their location. Let's look at the recti muscles as they appear on the eyeball observed from the front. They are the superior rectus, the medial rectus, the inferior rectus, and rounding out the circle, the lateral rectus. We now look from the back and observe 2 oblique muscles, the superior and inferior obliques. And remember what is key about muscles, we must know their innervation as well. But this is straightforward for the 6 eye muscles by remembering the following formula. LR6, SO4, all others by 3. Now, we need to understand how these muscles direct eye movement, and that may take some more effort to grasp. What we need to do first is simply look at the actions performed by the eyeballs, and here they are. Eyes can look toward the nose, that is adduction. Eyes can look to the periphery, that movement is known as abduction. Eyes can look upwards, elevation, or downwards, depression. And eyeballs can partially turn inwards, that is known as intorsion, or turn outwards, which is known as extorsion. The axis of rotation is through the pupil and optic nerve. Clearly, for normal vision, the muscles we have just described must work in synchrony to move the eyeball in the direction we wish to move it. Shortly, I will describe the specific actions of each muscle, but first, I want to describe some conditions in which the patients can tell that something is not as it should be. And generally, it is a parent that notices that something is just not normal with their child's eye. I list here some common questions that parents will raise when they start bringing their child in for checkups. Why is my child cross-eyed? Is this going to be permanent? Will he need surgery? What the parent has observed is strabismus, a condition in which the eyes do not properly align with each other when looking at an object. The eye that is focused on an object can alternate. The condition may be present occasionally or constantly. If present during a large part of childhood, it may result in amblyopia, or loss of depth perception. The word is derived from the Greek strabismus, which means squinting. The opposite of strabismus is orthophoria, exact ocular balance. And strabismus can be considered latent, in which case it is termed heterophoria, or it is manifest, in which case a proper term to use is heterotropia. Aberrant tracking of the eyeball also occurs with the eye being in an inward deviated position, a condition termed esotropia, or outward deviation called exotropia. And now in the image on the right, it is easy to observe the esotropia, but not sure anyone would notice the exotropia. But now cover the aberrant eye in both children, and you can clearly see that the left eye of the little girl was focusing on the examiner. Vertical deviation can also be an issue, and the vertical deviation can be either hypertropia, as shown here, or hypotropia. Pseudoesotropia can be difficult to confirm, as in this child. Again, we cover the eye that is not tracking correctly, and the gaze of the children focused on the examiner is now clear. As a review, here's a drawing of possible various forms of strabismus. Let's now go back to the muscles and gain an understanding of what each individual muscle attached to the eyeball does. The adductors are the medial, superior, and inferior rectus. The abductors are the superior and inferior obliques and the lateral rectus. The elevators are the superior rectus and the inferior oblique. The depressors are the inferior rectus and the superior oblique. Turning to the rotators, the lateral rotators, the ones that cause extorsion, are the inferior rectus and the inferior oblique, whereas the medial rotators, those causing intorsion, are the superior rectus and the superior oblique. As a review, I show how each individual muscle is capable of moving the eyeball. Let's look at this left eye that has the 6 eye muscles attached. We start with the superior oblique, the superior rectus, the lateral rectus, the inferior rectus, the inferior oblique, and the medial rectus. Knowing what the muscles do allows you to isolate an action of a particular muscle to test whether the nerve innervating the muscle remains intact. For example, look at the eye and the arrows. To test for the action of the lateral rectus, one only needs to ask the patient to abduct their eye. However, to test the action of the superior rectus, one needs to first ask the patient to abduct the eye, then have them elevated. Why is this? The explanation is in this set of drawings on the bottom panel. Look at the axis of the superior rectus muscle. The axis of the eyeball and superior rectus muscle are not parallel. Therefore, the superior rectus muscle cannot be isolated. However, once the eyeball has been abducted, the eyeball now is parallel with the superior rectus muscle. Therefore, only the superior rectus muscle can elevate the eye. Let's do one more muscle, this time the superior oblique. When we look at the axis of the eyeball and that of the superior oblique muscle, we note that they are not parallel. Therefore, the superior oblique muscle cannot be isolated. In contrast, once the eyeball has been adducted, the eyeball now is parallel with the superior oblique muscle. Therefore, only the superior oblique muscle can depress the eye. A detailed description of how to test for all 6 muscles of the eye is presented in this YouTube video. Please visit the site if you wish to gain additional information. We now move to the nerve supply of the eye, and we have discussed these previously. The nerves of the eyes are listed here: the optic, oculomotor, trochlear, ophthalmic division of 5, and the abducens. Let's go in order and describe what they do. The optic nerve is actually not a nerve, but an extension of the brain that is covered by meninges. It emerges from the posterior aspect of the eye, courses posteriorly within the retrobulbar space, and exits through the optic canal. The mechanism of how light is converted into vision will be presented in a separate lecture. I did present the visual pathway in the cranial nerve lecture, however, and you will be expected to follow it. I will not describe it again here in this lecture, except to remind you that it is the temporal visual field that crosses over, but the temporal retina fibers do not. Look closely at the image to appreciate why this statement is correct. Also, review again the direct and consensual pupillary reflex and understand why they occur and why they are used in emergency situations to assess patient status. Remember, however, more details about these pathways will be provided in neuroscience. Next, we move to the oculomotor nerve shown here in the drawing, entering the orbit through the superior orbital fissure and splitting into a superior and inferior division. The details that you need to know for this nerve are listed in the slide. It is motor to 5 muscles. It will provide preganglionic parasympathetic fibers to the ciliary ganglion and will be responsible for constricting the pupil and accommodating the lens of the eye. If damaged, it could simply prevent ptosis or droopy eyelids because the nerve innervates the levator palpebrae superioris. We again look at the trochlear and abducens nerves, and these are straightforward. Each is only motor to one muscle. The trochlear to the superior oblique, the abducens to the lateral rectus. Also, understand why double vision ensues if these nerves are damaged. Here, we see an isolated trochlear nerve palsy, which are rather rare. Given what you now know about the superior oblique muscle, it should be clear why the lesion results in diplopia and inability to rotate the eye in an inferolaterally direction due to the paralysis of the muscle on the same side. The eye deviates upward and slightly inwards, but the contralateral eye is unaffected. A person suffering from such a lesion will have difficulty in walking downstairs unless they cover the affected eye. If you ask the patient to look downwards towards the opposite side of the lesion, it will lead to diplopia. Isolated abducens nerve injuries are also quite rare. Isolated abducens nerve leads to medial squints with an inability to direct the affected eye laterally due to the unopposed action of the medial rectus. Diplopia will always be present except when looking opposite the side of the lesion. The last individual nerve we need to discuss is the ophthalmic division of cranial nerve 5. Once the nerve enters the orbit, it splits into the various components now indicated: the frontal, lacrimal, and nasociliary. The frontal will continue as a supraorbital once it exits the skull. Remember, all these branches are sensory, although the lacrimal nerve will ultimately be joined by postganglionic fibers from the pterygopalatine ganglion via zygomatic nerves. Let's again review the ciliary ganglion which you have seen previously. For this particular ganglion, we need to discuss its general sensory contribution, its preganglionic parasympathetic contribution, and its postganglionic sympathetic contribution. The sensory components of the ciliary ganglion are derived from the ophthalmic division of the trigeminal nerve. Fibers from V1 will travel to the ganglion, then pass right through to reach the eyeball and the cornea via the short ciliary nerves. In addition, note that fibers from V1 will bypass the ciliary ganglion and travel directly to the back of the eyeball by fibers known as long ciliary nerves. The preganglionic parasympathetic fibers to the ganglion will arrive there from the oculomotor nerve. Once there, the fibers will synapse at the ciliary ganglion and exit the ganglion as postganglionic fibers via the short ciliary fibers to constrict the pupil and accommodate the lens. Finally, postganglionic sympathetic fibers traveling with the internal carotid artery will jump to the ganglion or directly to the eyeball and provide sympathetic innervation of the eye. These are the nerves for fight or flight and will lead to pupillary dilation. Next, we consider the corneal reflex. The afferent pathway will be by V1. That is, if our corneas are touched, we blink. Given that the muscle responsible for blinking of the eyelid is the orbicularis oculi, a muscle of facial expression, the efferent pathway will be enacted by the facial nerve, cranial nerve 7. Before leaving the nerves, let's discuss Horner syndrome and understand its signs. If the cervical sympathetic trunk is somehow disrupted, for example, as a result of trauma or secondary to surgery, the manifestations are an absence of ipsilateral sympathetic stimulation. And the signs of Horner syndrome may include miosis, ptosis, and anhidrosis. The miosis will result because the sympathetic innervation to the pupil is interrupted. The pupil will be in constant state of constriction, even in the dark, as shown in the image. The drooping of the eyelid is because the tarsal muscles within the eyelid are not receiving innervation, and the absence of sweating is because, again, the patch of skin on the face is missing sympathetic innervation and cannot respond to stress. Individuals also lose the ability to become flush, and the reason for why some individuals choose selective surgery to abolish their excessive flushing. The last topic for the day is a blood supply to the orbit, and this is quite straightforward. All the arterial supply to the orbit is from the ophthalmic artery, a branch of the internal carotid. The ophthalmic artery is also the source of the central artery of the retina. Understand why any perturbation in the sole artery will result in loss of vision in that eye. There is no second source. The venous return, as you have now heard in various lectures, links the meninges to the danger zone of the face. Infection in the face can travel by way of the venous system to the cavernous sinus, leading to severe meningitis. As well, on rare occasions, a fistula may result in the internal carotid artery mixing arterial and venous blood, and a pulsation of the eyeball will be observed. A pulsating eyeball can also be the result of a congenital condition where the sphenoid bone is missing. Check out the indicated video on YouTube. This now concludes this video on the gross anatomy of vision.